Hello everyone and welcome to the channel. Today we are diving deep into a topic that sits at the very heart of post-cycle recovery and on-cycle estrogen management. We are putting two of the most talked about selective estrogen receptor modulators head to head. Clomiphene, yes the famous Clomid, and Tamoxifen, which you probably know as Novodex. If you've ever wondered which one truly reigns supreme for restoring your natural testosterone after a cycle, or which one is a sharper tool for keeping gyno at bay while you are still on, you are in the right place. We are going to strip away the broad science and build this comparison on a foundation of pharmacology, clinical data, and hard numbers. Stick around until the end, because the conclusion might genuinely change how you design your next PCT protocol. Let's begin with the engine room, mechanism of action. Both clomiphene and tamoxifen belongs to the class of drugs called selective estrogen receptor modulators, or SERMs. Now, a SERM is a molecule that acts as an estrogen blocker in some tissues while simultaneously acting as an estrogen activator in others. Think of it as a master key that can either lock or unlock a door depending on which house it's inserted into. This tissue selectivity behavior is what makes SAM so valuable and so complex at the same time. Clomiphene is a 3-phenylethyl derivative that works primarily as a competitive antagonist at estrogen receptor located in the hypothalamus. To put it plainly, clomiphene sits on those hypothalamic receptors and physically prevent the body's own estrogen from binding there. This is critical because under normal physiology, when estrogen docks onto those receptors, it sends a negative feedback signal that says, hey, we have enough sex hormone. Slow down production. By blocking that signal, clomiphene essentially tricks the brain into thinking estrogen levels are low. The hypothalamus responds by pumping out more gonadotropin-releasing hormone, which then travels down to the anterior pituitary and orders to release large amount of luteinizing hormone, LH, and follicle-stimulating hormone, FSH. LH is the primary driver that tells the Leydig cell in the testes to manufacture testosterone. Tamoxifen is also a 3-phenylethylene SERM, but its receptor binding profile is nuanced in a way that produces meaningful differences. While both drugs compete with estrogen at the pituitary hypothalamic level, tamoxifen displays a particularly strong antagonist effect in breast tissue. This is why tamoxifen has been the gold standard therapy for estrogen receptor positive breast cancer since the late 1970s. In the context of bodybuilding, that breast tissue selectivity translates into a powerful shield against gynecomastia that can occur when aromatizable androgens are present in excess. It's important to appreciate that tamoxifen itself is a prodrug. The liver converts it into endoxifen via the CYP2D6 enzyme, and endoxifen is 30 to 100 times more potent as an anti-estrogen than the parent compound. This is metabolic care that will become enormously important later when we discuss drug interactions. So, why do bodybuilders and fitness enthusiasts reach for these two drugs at all? The answer splits neatly into two phrases: on-cycle therapy, OCT, and post-cycle therapy, PCT. During the cycle of anabolic androgenic steroids, exogenous androgen can be converted into estrogen through the aromatase enzyme. When estrogen raises too high, athletes risk water retention, mood swing, and most feared gynecomastia. Tamoxifen is often the preferred OCT agent here because it directly blocks estrogen receptors in the breast tissue without crushing systematic estrogen, something that can be detrimental to lipid profile and joint health if overdone. Clomiphene is less commonly employed on cycle because its primary strength, ramping up gonadotropin output, is largely blunted while exogenous androgen are still suppressing the hypothalamic pituitary gonadal axis. Once the cycle ends, the game changes completely. The HPG axis is suppressed. Endogenous testosterone is on flow. Without intervention, recovery can take many months, and in some cases, the axis may never fully rebound. Post-cycle therapy exists to accelerate the rebound. Both clomiphene and tamoxifen elevate LH and FSH, which in turn reawaken testicular testosterone synthesis. However, clomiphene has historically been the go-to for PCT because it tends to produce a more robust gonadotropin surge, making it the heavy artillery for restarting the axis. In modern practice, many astute users combine both agents, clomiphene for its LH driving punch and tamoxifen for its breast tissue protection and favorable lipid effects, to create a synergetic PCT that covers multiple targets simultaneously. Let's get into the numbers. OCT dosing is not a one-size-fits-all affair. It's titrated against circulating estrogen and symptoms. For tamoxifen on cycle, when estradiol is mildly elevated and nipple sensitivity is the only complaint, 10 to 20 mg per day is typically sufficient. If estrogen surges are more pronounced, think visible puffiness or lump formation, the dosage can be escalated to 40 mg daily, split into 2 administrations for steadier plasma levels. Because tamoxifen doesn't suppress estrogen, but merely competes at the receptor, there is a ceiling effect. Pushing beyond 40 mg rarely yields additional gyno protection, but certainly amplifies side effect risk. Clomiphene is almost never recommended as a standalone OCT agent because its gonadotropin stimulating action is overwhelmed by exogenous androgen. Nonetheless, if someone were to experiment with it on cycle, a low dose of 25 mg every other day would be the starting point, though the clinical rationale remains thin and unsupported by robust data. The key take home is that OCT dosing should be guided by blood work. Without knowing your actual estradiol number, you are flying blind. PCT is where dosing becomes both an art and science. Clomiphene PCT protocols almost universally follow a front-loaded, tapered model. A typical regimen runs for 4 to 6 weeks, 50 mg daily for the first 2 weeks, then 20 mg daily for the remaining 2 to 4 weeks. The logic is straightforward. Saturate the hypothalamic estrogen receptor early to trigger maximal gonadotropin release, then ease off to allow the axis to regain its own rhythm without a pharmacological cliff. In cases of severe suppression, for example, after a long-range no-cycle, user open with 100 mg daily for first few days, though this high-dose approach carries a greater risk of visual disturbance and emotional lability. For tamoxifen PCT, dosing is equally tapered but at a different scale. A classic outline is 40 mg daily for week 1 and week 2, followed by 20 mg daily for weeks 3 and weeks 4. Some protocols extend up to 6 weeks if recovery lags. Combination PCT protocol often runs both drugs concurrently, clomiphene at 25 mg plus tamoxifen at 20 mg daily, tapering together over 4 to 6 weeks. The synergy is real. Clomiphene drives LH skyward. Tamoxifen keeps the chest safe. But this dual approach should be only attempted by those who monitor their liver enzymes, lipid panels, and visual health regularly. Now, for the numbers that matter. A landmark study demonstrated that 20 mg of tamoxifen per day for 10 days produced elevation in LH, FSH, and testosterone that were aesthetically comparable to those achieved with 150 mg of clomiphene daily, roughly a 7.5-fold dose advantage for tamoxifen on a per milligram basis. In a head-to-head PCT context, Clomiphene has shown to increase LH by approximately 142% above baseline, which is one of the most aggressive gonadotropin responses available from an oral agent. However, tamoxifen-treated subjects demonstrated a superior LH responses to LHRH after prolonged use, 6 weeks, suggesting that tamoxifen may synthesize the pituitary over time rather than merely a transient spike. When measured by total testosterone restoration, clomiphene therapy in hypogonadal men has shown reported to raise serum testosterone by roughly 168% after 1 year of continuous treatment. In separate cohort study, a mean increment from 223 nanogram per deciliter to 879 nanogram per deciliter, a 290% surge was documented with 100 milligram of clomiphene daily. These are pharmacological rescue data, not sport PCT data, but they illustrate the ceiling that clomiphene can reach. Tamoxifen, for its part, tends to produce a more gradual but sustained testosterone climb, and it adds the bonus of improving HDL cholesterol, a cardiovascular advantage that clomiphene doesn't offer. The punchline: clomiphene wins on sheer LH magnitude and speed, tamoxifen wins on dosing efficiency, breast tissue selectivity, and metabolic side benefits. Pharmacokinetics matter. It impacts daily dosing strategies. Let's discover half-lives. Clomiphene has a terminal elimination half-life of approximately 5 to 7 days. Its active metabolite linger even longer. 4-hydroxyclomiphene exhibits a half-life of 13 to 34 hours, but the parent drug's intrahepatic recirculation creates a depot effect that keeps plasma levels elevated for weeks after the last pill. This is why a single daily dose works perfectly and why the drug must be tapered rather than stopped abruptly to avoid a slow motion hormonal crash. Tamoxifen also boosts a long elimination half-life of 5 to 7 days for the parent compound, but its active metabolite, N-dosmethyl-tamoxifen, has a half-life of approximately 14 days, meaning a steady state concentration takes nearly 2 months to fully plateau. Consequently, even a short 4-week PCT produces pharmacologic activity that extends well beyond the actual dosing window. For the user, this translates to simple rule: once daily dosing is adequate for both agents, and tapering is non-negotiable. The long tails also mean that side effects can emerge late and resolve slowly. Both medications carry an undeniable side effect burden, and the profiles are surprisingly different despite their shared same classification. Clomiphene's signature adverse event is visual disturbance. User report blurred vision, floaters, and difficulty reading, with an estimated incidence of 5 to 10%. These symptoms are usually reversible upon discontinuation, but there are rare case reports of persistent scotoma. Beyond vision, clomiphene can provoke mood swings, lability, and in some individuals, a downright tearful affective states called clomid crying. Other side effects, headache, hot flashes, and gastrointestinal upset are common but usually transient. Tamoxifen's side effect catalog is shorter in the acute phase for male users. Mild fatigue, hot flashes, and occasional nausea, but its long-term risk signature is more serious. In women, tamoxifen carries black box warning for uterine malignancy and thromboembolic events, for example, deep vein thrombosis, a stroke, pulmonary embolism. For men using it in short-term and PCT, the absolute risk is low, but any user with a personal or family history of clotting disorders should approach tamoxifen with extreme caution. A From-based pharmacovigilance study analyzed 845 SAM-related posts and identified 157 adverse drug reactions with acne, musculoskeletal discomfort, mood disorders, and reproductive complaints being the most represented. Notably, 54% of SAM users reported some degree of impaired quality of life. A statistic that underscores these are not casual supplements. Vitamin D and calcium supplementation may mitigate the subtle bone turnover effects, and adequate hydration along with omega-3 fatty acid may support vascular health during tamoxifen-containing PCT. Here is where the differences become clinically consequential. Clomiphene's interaction profile is relatively modest. 15 drugs are known to interact, 14 of which are classified as major, including the same ospemifene and ACE inhibitor benazepril. Alcohol can potentiate dizziness and nausea, and existing liver disease is contraindication. Overall, however, clomiphene is a metabolically gentle molecule that doesn't heavily rely on a single polymorphic enzyme for its clearance. Tamoxifen is totally a different story because its activation to endoxifen depends on CYP2D6. Any drug that inhibits this enzyme can dramatically cripple tamoxifen's efficiency. The list of offending agents includes fluoxetine, paroxetine, bupropion, and even common over-the-counter compounds like diphenhydramine. In one study, co-administration of paroxetine reduced endoxifen concentration by more than 15%. A retrospective analysis of nearly 1,300 breast cancer patients found that concurrent CYP2D6 inhibitor use was associated with 13.9% recurrence rate versus 7.5% in those taking tamoxifen alone, a near doubling of risk. For the bodybuilder, the practical message is blunt. If you are on an SSRI, an SNRI, or even a regular sleep aid that interfere with CYP2D6, tamoxifen may be largely inactivated. In such scenarios, clomiphene become the safer, more reliable PCT choice. Tamoxifen also potentiates warfarin and other anticoagulants, amplifying the risk of bleeding. So, where does this leave us? Clomiphene and tamoxifen are not interchangeable. They are complementary instruments in the endocrine toolbox, each with its own fingerprint of power and prill. If your goal is to restart a profoundly suppressed HPG axis as quickly as possible, clomiphene's ability to drive LH up by over 140% makes it the most potent oral option available. If, on the other hand, you require uncycled gynecomastia protection without obliterating estrogen beneficial effects on lipids and neuroesteroids, tamoxifen's breast tissue selectivity is simply unmatched. The true sweet spot for many experienced users is a carefully dosed combination of both, a duet that attacks restoration from two different angles simultaneously. But never forget that these are powerful prescription medications, not lifestyle supplements. Blood work before, during, and after PCT is not optional. It's the bare minimum standard for self-care. Monitor testosterone, estradiol, liver enzymes, and a lipid panel. And if visual changes or unusual bleeding occur, discontinue immediately and seek medical attention. Ultimately, the best SAM is the one that aligns with your specific cycle history, your health status, and most importantly, your laboratory results. Education and prudence will always outperform blanket protocols. If this deep dive shed light on clomiphene versus tamoxifen decision, smash that like button, drop a comment below with your experience or the PCT protocol that has worked for you, and subscribe with notification on so you never miss an evidence-based breakdown. Train smart, recover smarter, and as always, please stay informed, stay safe, and look after your hormones for the long haul. We'll see you in the next one.